Good evening, everyone, and welcome to the ICU panel of today. We're going to start in 5 minutes, so please hold on. Okay, so good evening, everyone, and welcome to the fourth day of the 32nd International Pediatric Congress held by Tehran University of Medical Sciences. I'm Dr. Mariam Bakhtiari. I'm a third-year pediatric resident here in Children Medical Center, and I have the honor to be here with you guys and to host this meeting with you today. So this is the third of four ICU sessions that we've prepared for you. The next is going to be on Saturday on November 7th. Yes, I'm right. So don't forget to tune in there as well. So before starting our session, just a few reminders. Keep in mind to keep your microphones muted, to not disturb the lecturer as well. They're speaking. You can use the chat section below to write your questions, and we will read them and we will ask them maybe at the end of each lecturer's lecture, or maybe at the end of this session. We will see how we'll go. And for our Iranian audiences, if you want to receive CME credit for this session, don't forget to um, mm, participate in the CME quiz that is prepared. You have 2 days after this to participate in that quiz. The site is cmequiz.ir. And also for all of our audiences, if you want to receive the certificate of attendance for this panel, don't forget to subscribe and to register on our website. And we will email you and reserve a seat on this panel, and we will email you the certificate of attendance after this. Okay, so we have three very great and distinguished lecturers today with us. Actually, we had Professor Ajay Desai on the program as well, but he will join us on the Saturday event, and so we will have three today. So we are going to start with Dr. Cox, and I see him in the list. I think he's available now. Okay, so Dr. Cox, can you hear me? Hi again.
Hello, how are you?
Thank you. So before you start, I want to give you the introduction that I gave you yesterday. So because I think we have some new guests today, and I'm gonna make sure that I say the kilometers right this time. So Professor Peter Cox is a professor emeritus of anesthesia, pediatrics, and critical care at the University of Toronto. For many years, he was the fellowship program director for the critical care program at SickKids. The program has now trained nearly 500 fellows from close to 50 countries. He was also chief of the pediatric intensive care unit there. Dr. Cox is also an avid cyclist and last year completed a charity bike ride of 12,000 kilometers from Cairo to Cape Town and collected more than 250,000 US dollars for the cause of treatment of children with cleft palate in poor countries. After retirement, he has been active in clinical and teaching missions in Kenya, Malawi, Thailand, and Lebanon. So, Dr. Kuss, we're more than honored to have you with us today. We enjoyed your lecture yesterday as well, and we can't wait to listen to your lecture today and whenever you're ready.
Oh, thank you very much for that introduction. And for those of you that I did not speak with yesterday, good morning from Canada. It's evening time where you are. And yesterday we spoke a little bit about how we get gas into the lungs. And today what I'm going to speak about in a little bit more detail is the gas that I think is most important, which is oxygen. And the question that I ask and pose to all of us is hypoxia or hyperoxia really dangerous? I think there are many assumptions that we make in life, and one of them is about oxygen. I showed you a form of this diagram yesterday. By the way, can you see the screen okay, and can you hear me okay?
Yes, we can hear you.
Okay, Dr. Mohseni, but just down the road, agreed. So you must be in the right place. Okay, so we showed you this, and I'll come back to this in more detail, but what I want you to look at is on the right-hand side, which you've got an oxygen tension in the atmosphere of about 140 millimeters of mercury. And we just assume that that is there, and that's what we lived with. But I think it's important for us to reflect back in a little bit of history, and this is a graph that comes from a book on high-altitude physiology. And what I want you to look at is on the bottom scale here is the time scale, and it's looking at billions of years before present time. So here is 2 billion years, 3 billion years, and 4 billion years in the past. On the right-hand scale, we have present atmospheric level of oxygen in percent. And this double line is the net oxygen level. And what you need to focus on is that 2 billion years ago, there was not much oxygen. Oxygen began, you got oxidation of seawater constituents in the beginning of photosynthesis with cyanobacteria about 3 billion years ago, and brought us up to the current level of about 21% oxygen. How do we know this? This is a piece of rock, and on it you can see that there are dark lines, black, that's hematite and magnetite, and the lighter lines are quartz. What the hematite and magnetite are is that that's actually ferrous converted to ferric iron in the presence of oxygen. And we know that about 1.7 billion years ago, there was no more iron left in the seawater. So you don't get rocks that have this kind of formation after that period of time. So if you look at this graph, here we have 2.5 billion years ago, and you can see that the oxygen pressure is extremely low. But with cyanobacteria becoming more common, you get a gradual increase in the amount of oxygen until you begin to get first land plants. Remember that in water, here there is photosynthesis, so there is oxygen, but it's only in latter years that that oxygen actually came out into the atmosphere. And again, on the bottom scale, we've got time, and this is 250 million years ago. And we can see that you went from water breathing, where there was sufficient oxygen in the water, slowly to get air and water breathing. And an example here would be a frog. And it was only after that, about 200 million years ago, that you began to see reptiles crawling out of the water onto land, and eventually evolution of birds and mammals. So just to summarize, prior to 2.8 billion years ago, there were only terrestrial oxides. But since cyanobacteria became more available, you began to see photosynthesis, and using water as a reductant, you could split the water into oxygen, protons, and electrons, and allow accumulation of oxygen in the atmosphere, and therefore life as we know it. And so now we can go back and look at this diagram, and we've always assumed that there's 20% oxygen or 140 millimeters of mercury of oxygen in the atmosphere, and we can breathe it in. And as we do that, that oxygen is delivered down to the mitochondria, where it is consumed within the body. Oops, next slide. So the question that I think we need to ask ourselves is that we understand that hypoxic cellular dysfunction and necrosis, occurs in the presence of hypoxia, but oxygen toxicity is not without its own problems, and that is both within the lung, within the brain, and within the eyes. And so we ask ourselves, those of us who work in an environment where we are able to deliver an increased amount of oxygen, whether or not it's the right thing to do. So just to refresh your minds with oxygen in the body, fundamentally, it's a balance between supply on the one hand and demand on the other. And to remind you, oxygen delivery is equal to the cardiac output, that's the heart up in the top right-hand corner, times the hemoglobin concentration. Here's an oxygen hemoglobin dissociation curve in the top left-hand corner, times the solubility, times oxygen saturation of hemoglobin. And I put that in bold as that is the most important factor for the amount of oxygen that's actually delivered to the tissues. So if we think of situations of insufficient oxygen, the one that we're all most familiar with, those of us who work in the clinical world, is that of an infant. And sorry, not an infant, a fetus. And a fetus, the supply is completely fixed because the fetus is dependent on the mother's placenta for all of the oxygen that allows nutrition, metabolism, excretion to come through this placenta and allow the fetus to actually grow. In situations of fetal hypoxia, we know that you get a fetal growth retardation, small babies, and so what the fetus does in situations of hypoxia, tries to maximize consumption by decreasing metabolism, decreasing fetal movement, and a loss of heart rate variability. And for those of you that have worked in an obstetric clinic, you will know if you're able to monitor the fetal heart rate, And when you get a loss of heart rate variability, the baby's in trouble and it's time to come out. And that is often when you'd have a precipitous or urgent delivery. What I haven't commented on is what's in the top left-hand corner, is that in a fetus, the maximum PaO2 is 30 millimeters of mercury. Now, if you put yourselves in a clinic or in an ICU and you get a PaO2 of 30, you're actually worried and want to do something about it. The average PaO2 is only 15 to 21 millimeters of mercury. That's extremely low. And that's in a fetus. Of interest is that if you look at the fetus, and this is this column here on the left-hand side, this vertical column, and you compare them to a typical adult male or female, you can see that the PaO2, and I'm now talking in kilopascals, not millimeters of mercury, is 2.5 to 3.5 in a fetus and about 13 in an adult. The oxygen saturation, remembering that you're dealing with some fetal hemoglobin, is 65 in a fetus, where it's 98 in an adult. And if you look at the arterial oxygen content in a fetus, it's 150, and in an adult, it's 200. What's important is this column in the middle, where they've done measurement on climbers on Mount Everest, looking at oxygen, carbon dioxide, and many other factors, and I'll touch on some of them in a minute. But I think it's important for you to note that this is at 8,400 meters, so that's about 400 meters below the summit of Mount Everest. The PaO2 in kilopascals is not a lot higher than it is in a fetus. Equally, the oxygen content is also not much different from what it is in a fetus. It's a bit different from what it is in an adult, but not much different from what it is in the fetus. And I'm not going to get into how a lot of that compensation goes on, other than to say that we know that as you go up a mountain to the top of Mount Everest, that's 8,848 meters, the atmospheric pressure drops, and therefore the partial pressure of oxygen will drop. And on this graph over here, these clear bars, that's the partial pressure of oxygen, and it drops as you go up the mountain. The next column that there is oxygen saturation, and you can see, as you'd expect, that the oxygen saturation drops, but it doesn't drop nearly as much as you would expect it to. The third column is one of the compensatory mechanisms, and that's the hemoglobin concentration. If you spend enough time acclimatizing, walking up Everest, which I've been fortunate to be able to go up to about Camp 2, your hemoglobin actually increases. And if you go back to oxygen delivery, hemoglobin concentration is a very important factor in the amount of oxygen that you deliver to your tissues. And because of this, the arterial oxygen content, which is these darker green lines, stays very, very similar until you get right near the summit. So the body is able to cope quite effectively with hypoxia. Why do I talk about mountains in a fetus? Because in the bottom of this triangle is a patient in an intensive care unit. And this is what we, those of us who work in this environment, deal with on a regular basis. And in the middle of this triangle are the factors that the body actually uses to compensate in times of hypoxia. This is one time of hypoxia, the fetus. This is another, going up to high altitude. And the third is patients either in a clinic or on a ward or in an intensive care unit. And some of the mechanisms that the body actually has invoked to compensate is HIF, which is hypoxia-inducible factor, and I'll talk more about that in a minute. Nitric oxide, we've learned in an ICU to use permissive hypoxemia. Another factor that's of interest here is carbon monoxide, and carbon monoxide is actually produced within our bodies under periods of hypoxic stress by endogenous enzymes. And what that does is it downregulates some of the factors to allow us to survive in times of hypoxia. How do we know all this happens? So these are some experiments done in tiny mammals. I think these were rats, done some time ago. And what they did was that they exposed these animals to periods of what they call ischemic preconditioning, but essentially they decreased the amount of oxygen that the animals was breathing in from 20% to 8%. And they did this for variable amounts of time and variable durations of time. So variable times before they induced cerebral ischemia and variable durations before they induced cerebral ischemia. And what they measured was hypoxia-inducible factor, vascular and endogenous growth factor, erythropoietin, which, as you know, stimulates hemoglobin. And they also then sacrificed the animals and measured infarct size. Interesting to note, I'm just going to get you to focus on these pictures at the bottom. In the control animals, the infarct was that size. And in the animals that were experimented on, the size of the infarct is quite dramatically different. As you can see, it's about half the size of what it was before. The other thing that they did was that they measured, these are different durations of hypoxia, different times before sacrifice, but they measured erythropoietin and vascular endothelial growth factor and demonstrated that this increased over time. So what we were able to deduce from these experiments is that in a fairly rapid system, the body actually responds by producing certain elements that allow the body to better cope with hypoxia. It's a very pretty little diagram, but that's what hypoxia-inducible growth factor looks like. And this is one of the factors that they were able to measure. And what we know that this hypoxia-inducible factor, or HIF, what it does is it upregulates in times of hypoxia, erythropoietin, angiogenic factors, that's VEGF, and vasoactive mediators to maintain oxygen delivery. It also induces glycolytic enzymes to optimize metabolism, and it depresses oxygen consumption in the mitochondria. So something that certainly I didn't know about in the 1990s is one of the mechanisms that our body is actually produced to deal with hypoxia. The others is that, and I'm not going to go into this in detail, but there's a number of oxygen species, nitric oxide and carbon monoxide and hydrogen sulfide, all of which are factors that are protective of cells in hypoxic situations. And then I put on the left-hand side of this slide an oxygen dissociation curve demonstrating that fetal hemoglobin is more effective at picking up and carrying oxygen than adult hemoglobin is. And we know that in times of hypoxia, this curve actually shifts to the left. Important physiological mechanisms. Does all of this mean anything in humans? This is some work done in 2011, where they actually took an ultrasound machine up to nearly 8,000 meters on Everest. And what they did was they measured cerebral vasculature and flow using an ultrasound machine. And interestingly, I'm not going to go into all these graphs, but they could show that as they went up, there was vasodilatation. This is mean cerebral artery diameter, and you can see that it increases. And by increasing the diameter, you decrease the resistance and you increase flow, and so you're able to increase oxygen delivery. That's this graph in the bottom left-hand corner. Clearly, we know that the saturation will decrease. This is venous, and that is arterial, but we are able, by increasing oxygen delivery, to maintain what the body requires at those altitudes. So that's basically how the body copes with hypoxia. What about giving oxygen? I put this slide in just out of interest because this is actually a reptile. It's a frog, sorry, an amphibian. And this frog does not have any lungs. All of the breathing is actually done through the skin. Now, we don't have that ability in humans. And we often deal, particularly those of us who work in neonatal units, with persistent pulmonary hypertension of the newborn. That's the best example. And certainly when I went to medical school and in my early days in training in pediatrics, giving kids with pulmonary hypertension 100% oxygen was state of the art at that point, and that was in the belief that it caused significant vasodilatation in the pulmonary vasculature and thereby decreased pulmonary vascular resistance and allowed these infants to survive. That has been questioned, and many of the younger members in this audience will know that you now do not use these very high levels of oxygen. These are some experiments done in Denver, Colorado in 2009, published in 2009. And we've got 4 graphs, or 4 lines. There's the dotted line, which is the control. These are animals without having pulmonary hypertension. And then this is done in lambs, actually. And then there are 3 others. There's the circles, which is animals given 100% oxygen, triangles given 50% oxygen, and squares given 21% oxygen. And I want you to look at 2 graphs in particular. The one is pulmonary blood flow, and you can see that there's very little difference, no significant difference in 100%, 50%, and 21% oxygen. Equally, if you look at pulmonary vascular resistance, that's this graph up on the right-hand side, top right-hand corner, you can see that there's no difference between these different concentrations of oxygen given to these sheep or lambs. So what we know from this is that resuscitation with 100% oxygen does not enhance pulmonary vasodilatation compared with 21% and 50% oxygen. But it does impair, this is another part of the experiment I didn't include here, subsequent responses to inhaled nitric oxide. In 2004, Davis looked at a whole number of different papers looking at the administration of 100% oxygen. And what he was able to show in this pooled data that there was a reduction in mortality seen in infants resuscitated with room air, and there was no evidence that harm has been demonstrated. Now remember that these experiments were done prior to pulse oximetry the way that we have it today. When pulse oximetry first came into practice in the late 80s, early 90s, it was fairly inaccurate, under or below levels of about 93%. Now that we have better pulse oximeters, we're able to have a better idea of what we're actually doing, which has led to a whole number of studies done looking at what is the optimal oxygen saturation to give to either newborns or premature newborns without risking eye problems, ROP, or other oxygen toxicity, but at the same time avoiding significant hypoxia. And that's one of the studies. Here's another one. This is by Askey in 2003. And fundamentally, what these studies have showed, and this is from one of the papers, but the findings are all pretty similar, is that if you look at a standard saturation, which is aiming for a saturation of about 92, versus a high saturation, which is aiming for a saturation of about 96, 97, in the high saturation group, there was much more dependence on oxygen at 36 weeks post-menstrual age. You can see 64 versus 46%. And in addition to that, double the amount of kids went home with oxygen therapy if they were given high oxygen saturations while in the neonatal intensive care unit. And the last factor that we've got here is that they were given oxygen therapy for a much longer period of time, 40 days versus 17 and a half days. So what we've learned from this is that targeting a high oxygen saturation in premature infants who are dependent on supplemental oxygen didn't confer significant benefit with respect to growth and dependence on oxygen post-discharge. Questions that then came up was, what is the target range that we should aim for? And there was a lot of debate on this, looking at retinopathy of prematurity and death as the primary outcomes. And what we can show from these studies is that a lower target range of oxygen, that's 85 to 89%, as compared with a higher, 91 to 95%, resulted in an insignificant increase in mortality. You can see there's a change over here, but a substantial decrease in retinopathy of prematurity among survivors. So again, a whole bunch of other studies, but essentially what they showed is that in extremely premature infants, targeting saturations had no significant effect on the rate of death or disability. And I think that's an important thing because people tend to focus on trying to maintain a much higher oxygen level than is actually required for survival. Some of you may know who this individual is, and he's a great vocalist. His name is Stevie Wonder. And if ever you look at a photograph of him, you will see that he always has dark glasses. Now, Stevie Wonder was born at 34 weeks of gestation, which in today's terms is not anything to worry about, but this was in 1950. And he was put in an incubator and had oxygen piped into the incubator for his early period of life. And as a result of that, he developed retinopathy of prematurity and is subsequently blind. And so that's a reminder in a real human face as to what can happen if you give oxygen in a concentration that's higher than is actually needed. I've spoken about neonates and babies and infants, but what about older people and giving them oxygen? So there've been, if you think about what's been drummed into you since when you first went to medical school, is that we know that patients who have a cardiac arrest, many of them who have resuscitation, do not survive to leave hospital. And the most common cause of mortality is post-arrest brain injury. And we know that the brain is extremely sensitive to both ischemia and to reperfusion syndrome. And so we teach and you learn that the goals of therapy post-cardiac arrest are to avoid secondary brain injury. And it's drummed into us that you've got to avoid hypoxia. You've got to maintain a good arterial blood pressure, try and keep the temperature within a normal range and make sure that there's enough glucose. So this avoiding hypoxia is something that may actually lead to a problem. This is a study done looking at 6,000 patients who had non-traumatic cardiac arrest and compares those patients who had a PaO2 of greater than about 250 versus those where a PaO2 was maintained at about 100. And you can see on the vertical axis here, this is the survival proportion, and patients who were given more oxygen to give them a PaO2 greater than about 250, a much smaller percentage of them survived than those who had normoxia. So giving oxygen is not without a fairly significant risk. There's another study that looked at infarct size. And what they showed in this study is that, I'm going to go straight to the conclusion, is that the routine use of high flow oxygen in uncomplicated myocardial infarction may result in greater infarct size and possibly increase the risk of mortality. So here you have two situations. The one is cardiac arrest and the other one's myocardial infarction. And in both of those, giving more oxygen than the body actually needs may be harmful. This is another study presented in 2014, but again, the same conclusion is that hyperoxia appears to be correlated with increased in-hospital mortality. So it's important for us to ensure that we don't give more oxygen than patients actually need. And there are many things that we can measure that will help guide what the right amount of oxygen is. This is a further study, and I'm just showing you that it's not an isolated study. There's a lot of information out there that shows that hyperoxia is not associated with an increased survival in patients. But importantly, this does not mean that when you are resuscitating a patient, you shouldn't be giving them oxygen. Because at the time of resuscitation, you're dealing with very poor cardiac output, and you want to ensure that what you're delivering to the cells is as much oxygen as you possibly can. However, as soon as your oxygen saturation can be measured reliably by pulse oximetry or by arterial blood gas, you must titrate the oxygen that you're delivering to your patient, this is adults or children, to an arterial oxygen saturation of about 94 to 98%. So we've spoken about giving oxygen, that's the inspired oxygen, but what about oxygen delivery? This is two studies, both of them are done in the 1990s, but I've used this just to try and illustrate that when you think about oxygen, you shouldn't only think about what you're inhaling, you should also think about what you're delivering and how you're delivering it. On the left-hand side is a study done by Paul Heber, published in the New England Journal of Medicine in 1999. And what he did was, this is purely looking at transfusion to increase the hemoglobin level. And on the vertical axis, you've got survival. On the horizontal axis, you've got time in days. And these are different Apache scores and different ages. But the bottom line is that those patients who were given more hemoglobin by blood transfusion actually had a poorer survival than those who were not given as much blood transfusion. An important thing to remember, giving hemoglobin, we go back to oxygen delivery, which is your reason to give it, but it's not without harm in and of itself. This is a study done also in the New England Journal of Medicine, 1994. And what these investigators did was that they looked at, again, oxygen delivery, but they increased oxygen delivery by using an inotrope, in this case, dopamine. And you can see, and there are two groups of patients. Here's the control. This is the study group. There's a significant increase, about 1.5 times increase in oxygen delivery. However, oxygen consumption stays pretty much the same. But most importantly, those patients who had increased delivery with the use of inotropes had poorer outcome. In other words, more of them died than in the control group. So here you've got giving, on the left-hand side, giving patients added hemoglobin, on the right-hand side, increasing cardiac output. Neither of those actually increased the survival in patients from an intensive care unit. So what we're increasingly dealing with is a permissive hypoxemia. And initially, when I started, we always tried to normalize everything, but I think that all of these studies over time, and this is including the ARDS network trial, is that the clinical outcome of patients in an ICU has got far less to do with the actual amount of oxygen delivered to the blood cells, other than making sure that it's enough. It shouldn't be too much. And what we need to do is to focus on the detail and ensure that we are delivering enough oxygen, and we can measure that, and that we try and decrease the demand for oxygen within the body. So the supply side is cardiac output, hemoglobin, and saturation, and must make sure that you balance that against the oxygen requirements or the demand within the body, and measures that you can get of this are using the mixed venous oxygen and lactate. So like everything in clinical medicine, it's attention to small details. I haven't told you anything that is fancy or requires fancy equipment. All that I've told you is that you should really think about what you're doing and recognize that as physicians, young physicians, and some of us are older physicians, every single thing that we do with a patient has a degree of risk, and we should always balance that risk against the benefit. And this applies as much to giving oxygen, which we assume is a pretty benign agent. What I've shown you is that it's not a benign agent, and in fact can cause significant morbidity and mortality. And with that, I thank you very much. That's the end of my talk this morning, and I'll be open to questions.
So, thank you, Professor Cox, for this amazing lecture. It was really great to hear you again after yesterday, and also the points that you mentioned, like DO2 and SO2 and the oxygen delivery, and also this point that you mentioned that and in those studies, the Paxil transfusion and even inotrope infusions did not improve the outcome of these patients. It was really interesting, and thank you for that. So, Dr. Qari, would you want to add anything to this?
Thank you very much, Professor Cox. That was very interesting for us. You had two great speeches for us. It was very perfectly designed and explained. I appreciate it a lot. About the amount of hemoglobin, we cannot, you talked about the side effects and the problems which we may have by transfusing and packed cell and increasing the level of hemoglobin, but we can never convince our cardiac surgeons after 8 hours of a complicated procedure that, especially when they have when they have operated single ventricle or putting MBT shunts or doing palliative surgery, or in a patient with pulmonary hypertension, that we may follow a restrictive transfusion policy. Even in this kind of patients, with palliative surgery, for example, or with severe pulmonary hypertension, shall we follow a restrictive transfusion policy? Because, for example, our policy in our ward, in our post-cardiac operation intensive care ward, is in palliative surgeries, we increase the hemoglobin for more than 14. And our surgeon will never be convinced to following a restrictive policy.
I'm delighted to see that Dr. Humpl has joined us on the screen. And I think that there isn't anybody who is better placed to answer that question than Dr. Tilman Humpl. Thank you, Tilman.
Okay. Thank you very much. Thank you. Thanks a lot.
Tilman, can you answer the question?
Excuse me.
Your microphone's not on, Tilman.
Just replied to a text message that was clinically related. Can you repeat the question, because I didn't hear it?
So the question fundamentally was, I spoke about oxygen delivery, and one of the components I spoke about was not over transfusing. The question was that while we understand that it's very hard to convince our cardiac surgeons, particularly in palliative surgery, palliative surgery and pulmonary hypertension, not to transfuse them to a hemoglobin of about 14 or 140.
I think there's no real good evidence-based data. I think it comes more from studies that we learned previously, that this seems to be the level that's acceptable, both not having too much red cells on board, not over transfusing, but also not using too much oxygen. From my perspective, there's really nothing out there that makes the number 14 or 140 the right one or the wrong one.
Can I ask a question? Hello, Tilman. How are you? Can I ask a question from both Tilman and Peter, and also bring up a point? From Peter, you said that you showed us that those graphs from the pediatric research, that giving 100% oxygen did not change the pulmonary vascular resistance, nor did it increase the PaO2. But we know that in the cath lab, we take people who have so-called reactive vascular bed in their lungs and give them 100% oxygen, and their pulmonary blood flow goes up, and their systemic PaO2 goes up. Is that so? The patients that researcher worked on, were they all children who had completely normal vasculature, or the observation is a bit different from what he showed. The second question that I had was that I remember from the past that in people who didn't have a intracardiac shunt but had pulmonary hypertension, a hemoglobin of 9 or 10 had, because of the rheology of the red cell and the viscosity of the blood, had less risk of pulmonary hypertension increased compared to people that had hyperviscosity of the blood. So, but I know that people also talk about oxygen delivery and higher oxygen. The only condition that I remember from clinical practice we gave 100% oxygen to the child was as in children with Jehovah's Witness, or who had a hemoglobin of 2 or 3 grams, and in those, if you increase the oxygen content, you might, because normally PaO2 does not contribute that much to the total oxygen delivery, but in somebody who has a hemoglobin of 2 or 3, and is a Jehovah's Witness, which you probably don't have any on, or if you don't have blood to give to the child, then that might be one situation that you would give 100% oxygen. But
Hadi, right? You're a little bit going to the extremes if you say a lowish hemoglobin and a highish. And I think the truth is as many times in the middle. So I would, in my practice, I always kept the PH patients somewhere with a hemoglobin of 12 to 13. Completely agreed. You have to have some oxygen carrier. So a patient who is anemic will not survive. PH patients have a shortened life anyways, and patients who have a hemoglobin of 18 also have problems. So I think not moving to the extremes, but maybe that's the same thing with the 14 for the palliative patients is somewhere where people agree to be in the middle and not on either edge.
And just to go to your first question, Hadi, that was actually a study done in fetal lambs and delivered in lambs. It was not done in humans, but I think the data has been extrapolated to being used in humans. And Tilman, you can comment on pulmonary reactivity with delivery of oxygen in the cath lab, which clearly is different.
Yeah, absolutely. So oxygen is used or was used early on before nitric oxide was available. It's a vasodilator in the pulmonary artery bed. But nowadays, if we test in the cath lab, we usually use oxygen, then nitric oxide, and then both together. This is currently the gold standard. And you see some kids or some adults reacting to oxygen only. Some kids don't react to oxygen, some others react to nitric oxide. But the main point is there reactivity in the pulmonary artery bed, because this at the end will guide therapy.
So thank you, everyone. And thank you, Dr. Cox. Thank you, Dr. Mohseni. And again, and welcome to Dr. Humpl. We're so honored to have you today with us. So I see Dr. Sharifzadeh has a question. Dr. Sharifzadeh, can you hear me?
Yeah, thanks. Hello, dear professor, and hello, Professor Cox, for your very great lecture. And I have a question about hypoxemia in ICU. You explained us about the danger of hyperoxia in the treatment of hypoxic neonate and hypoxic patient, but we have a great problem in ICU about hypoxia, for example, in the treatment of acute respiratory distress syndrome. Sometimes the degree of SO2 is declined to about 80% or even 75%. What degree of hypoxia and the result of it, hypoxia, could be tolerated in the treatment of hypoxic patient, for example, ARDS of heart or heart failure in ICU?
Can you hear me? I think that.
Oh, no, we can't. We don't have your voice.
Can you hear me now?
Yes.
Okay.
I can hear you. Thanks you.
Okay. I think the important thing when you're working in any clinical situation is that giving an absolute number to set as your goal doesn't work, because humans and human physiology is dynamic, and you need to adapt what you're doing to the situation in front of you. So I fully understand your question that in situations of significant ARDS, you have profound hypoxemia, and you are often mandated by the patient requirement to give them 100% oxygen. However, my comment is that you should not be aiming for a saturation of 100%, and your saturation level may need to be adapted as the disease progresses and evolves. There are other things that you can do to decrease oxygen consumption. This would be to ensure that the patient is not febrile or hypothermic, it doesn't have a temperature, the patient isn't shivering, that you can muscle relax or very nicely sedate the patient, and you can decrease oxygen consumption, because remember, it's a balance. The other thing is from the ARDSNet study, given that that's now 20 years old, but even in that study, they demonstrated that hypoxemia by itself was not the contributor to increased mortality and morbidity. Rather, it was how the ventilator was used. So I'm not going to tell you to aim for a saturation of 75%. There are situations where your lung disease gets so bad that you are unable to oxygenate the patient and the patient will die. That's part of the environment in which we work. However, what I am going to ask you to do is to make sure that you don't only focus on the oxygen saturation, but you also focus on the factors that you can nicely control that may be contributing to increased oxygen consumption. So it's a dynamic process, and as in everything, it's a bit of a balance. There's not an extreme on either side. And I'm not sure that answers your question, but it's the best that I can do, unless one of the other speakers has anything to add.
Thank you, Dr. Cox, for this great explanation. So I don't see any other questions. It was really amazing to hear this discussion for me as a pediatric resident, and thank you all for joining in the discussion. So next we're going to go with Professor Tilman Humpl. So Professor Tilman Humpl is a professor and chief of pediatric and neonatal intensive care services at the Children's Hospital in Bern, Switzerland. Before that, he was associate professor at the University of Toronto. He's one of the international authorities in pediatric pulmonary hypertension as well. In Toronto, he was Director, Pulmonary Hypertensive Service, Medical Director, Ventricular Assist Device Program, and was also Program Director for Training in Pediatric Critical Care Medicine. He's an avid sailor and also a very big football fan. So thank you, Professor Humpl, for joining us again. We are really honored to have you, and we are ready to listen to your lecture whenever you are.
Yeah.
Yes.
Thank you very much for this nice introduction. So first I have to get my screens, my slides on the screen.
Yes. Yes. Yeah. You should open your PowerPoint first, minimize it, and then come to the Zoom windows and choose the share screen button down there.
Share screen.
There's a green button. Do you see that? Let me make you a co-host. Maybe you can see it now.
Let me see. I have to open system preferences on the Mac. Yes? No. Oh. Peter, how did you do that?
Tilman, can you see me on the Zoom screen?
Yes.
Okay, put your mouse on the Zoom screen, put it over your face.
Over my face?
Well, just because that will bring up at the bottom, there'll be a share screen button.
Yeah, I see the share screen, but then it comes a completely crazy thing comes up.
And
Keynote.
what should come up is a lot of little screens.
Yeah, but it doesn't.
One of those little screens is your presentation.
But it's little.
Little rectangles.
Yeah.
Yes. So I can see you in the desktop. If you,
have you opened your?
Have you got your PowerPoint open on
Yes.
your screen?
Dr. Humpl, you froze.
It's
Yes.
Yes.
Can you see your PowerPoint behind the screen?
That's funny. Can you see that now? Oops.
Not yet.
Technology. Or Hadi, you want to go ahead and give your talk, and I play around with this machine?
Okay.
Is that
So
okay?
I initially had the same problem as you, and somehow it just resolved. I saw that it asked about preferences and things like that. And then I clicked on my PowerPoint a couple of times, and then it showed up in the background, and I shared it. So I don't know what I did, but I just clicked on the PowerPoint a couple of times. It showed up in one of the.
Tilman, I'll give you a call.
Yeah, just a second. I'll see if what happens now. Can you see something?
No,
Okay.
not yet.
See you.
See me. One more thing. Okay, so why don't you go with Hadi and I do it after.
Okay.
Okay.
So, yes, okay, it will be fine. So, Dr. Mohseni, we're here with you. So, let me give you an introduction also as well for our guests today. So, Dr. Hadi Mohseni from Khorasan was trained in medicine at Tehran University of Medical Sciences. He then continued to train in pediatrics, pediatric cardiology, and pediatric critical care, and also tropical medicine in the States, England, and Canada. Dr. Mohseni was on the teaching staff at the Hospital for Sick Children and the University of Toronto until 2015, when he started working with humanitarian missions in Sub-Saharan Africa. He has worked in Southeast Asia, Sub-Saharan Africa, and Central America. Currently, he's an ordinary staff at the PICU of the Hospital for Sick Children and works with the Doctors Without the Borders and Canadian Red Cross. So with this introduction, Dr. Mohseni, we are all ears. And thank you for joining us again.
Thank you very much. Can you hear me well?
Yes, and we can see your slides.
Thank you very much. So, I'm not going to be able to cover, the topic of hemodynamics or CVP or monitoring, invasive monitoring in ICU. So I'll talk mainly about CVP and a little bit about fluid or volume bolus in ICU. What we're going to cover is a bit of physiological meaning of CVP, how to measure it, and what does CVP tell us about volume status and fluid responsiveness? Does it provide helpful information and harms of a high CVP? And a bit about fluid boluses at the end. So we have a pre-test here. So you're all healthy, young people sitting upright. Maybe some of you are lying in a supine position because nobody can see you. But what is your average CVP right now, all of you healthy sitting people? -1 to 0, 4 to 5, 5 to 8, 8 to 12, 12 to 15. Those are all in millimeters of mercury. And the second test is that in a resting giraffe, obviously resting giraffe is not going to be resting when people are around. So this was an anesthetized resting giraffe standing up. The head of the animal is about 2 meters above the level of the right atrium. What's the normal CVP in an adult giraffe while standing? And you remember the conversion 1.36, so 200 centimeter water is about 147 millimeters of mercury. So is the CVP 147, or is it 2 to 5, or is it 5 to 8, or half of the 147, 70 to 80, or is it 15 to 20? The reason that I put the giraffe is a bit of a joke, but the human, because most people think normal CVP is a lot higher than what it is. So those are the answers. So in an adult or in a young person sitting upright, the CVP is 0 or -1. And in a standing giraffe, despite the long neck of 2 meters, 2 to 5 millimeters of mercury. So what we're going to talk today is mainly concerning patients with sepsis. I'm not talking about patients with congenital heart disease or people who have, one ventricle or those, all sorts of abnormal venous connections. At the beginning, I think we all have to go back to our medical school and remember Guyton's model of blood flow. So what Guyton did, which was in addition to what Frank and Starling did about 70, 80 years before him, was that he brought up this model of cardiac function and venous return function. And the CVPs in the interaction, or if you will, equilibrium between the cardiac function and the venous return function. So cardiac function included the function of the RV and the LV and the pulmonary circulation in between them. And what we talk about as preload, which CVP we were taught is a representative of, was the final pressure in the ventricle, either RV or LV, before the onset of systole. And it set the final ventricular end-diastolic volume based on the compliance of the ventricular wall. Why pressure when we talk about volume? One is that it's very difficult to measure volume. And two, it's because if you remember the Frank-Starling curve, when the heart is filled up, when you reach the limit, then the pressure will go up if you put more volume in it, but volume will not go up. So it's more even physiologically sound to measure the pressure rather than the volume, if we could measure the volume. As such, it is best physiologically sound to measure the final pressure in the RV if we want to measure, for example, the preload of the RV systole, and not look at the average CVP or the RA pressure. That's what the monitor does, gives you an average number. The venous return function is mainly determined by the vascular volume, venous compliance, venous resistance, and the downstream pressure, which is the CVP. If you remember, most of the blood in the circulation is in the venous compartment. And another thing that you have to remember is that the vascular volume has two components, a stressed volume and unstressed volume. You know, unstressed volume is the volume that does not cause pressure until it reaches a level that above that, then it causes wall stress and produces pressure. Normally, only about 30% of the blood is in the stressed volume component. So to make it easier to understand, this is the tub analogy, which is from Simon Gelman in Anesthesiology 2008. So if you look here, this is what is characterized by a stressed volume. This is the upstream pressure, and this is the downstream pressure here. This hole in the wall of the tank, which is the venous resistance, determines, you know, if there's a big hole or a small hole, how much is the venous resistance and venous compliance. And if this hole is up here or down here, and then it determines how much is the stressed volume. Normally, only about 30% of total blood flow is here stressed. So this amount is a so-called sequestered volume. This does not have any role in producing venous return to the heart. And when we talk about the blood volume, you know, basically we may not have any idea how much is this component. So if you move this one up or down, we should do it by either giving volume and making this higher, or by giving vasoconstrictors. Then you change that gradient for the upstream and downstream pressure. So this is how these curves look like. This is the this is the venous return curve or venous return function. And this is similar to the Frank-Starling curve, if you remember, the cardiac function. Both of them have a limit. This is the limit for the venous return curve, and this is the limit for the cardiac function curve. The limit of the cardiac function curve reaches because of the pericardium. That's in an intact heart. In an isolated heart, that will be because of the cytoskeleton of the heart. In a venous return, this is zero, when the pressure goes below zero or less than zero, then you have the collapse of the vein. Then something happens, which they call it waterfall phenomenon. So then the pressure head, or the pressure that produces flow, is between the upstream pressure, which is called, I'll talk about it, mean systemic filling pressure, and that point, not the right atrium. So what is the CVP? CVP, or the working RA pressure, is the interaction of these two curves. So the reason I put this here is that the only way to understand what the CVP represent is to have an idea about the cardiac function curve, which at the bedside is very difficult to have a Frank-Starling curve for every patient made in your head or on a monitor, and about the venous return. So this is a slide from Magder, a representation of that idea. So the reason that this is the arterial system, the reason they're disconnected hydraulically, if you will, or pressure-wise, because the arterial and arterial resistance is very high. So that's the reason that the main component that determines the venous return is this so-called mean systemic filling pressure. Mean systemic filling pressure in physiology is a pressure that is difficult again to measure, but it means if the heart stops suddenly, and you measure the equilibrium pressure in the venous system or in the total circulation, that's called mean systemic filling pressure. And that is the upstream pressure for the venous return, and the CVP, or this point, is the downstream. So what we meant by preload, because the experiments were first in the isolated muscle fiber, the preload was the amount that the muscle was stretched before it contracted. So the length tension relationship was the preload. For an intact heart, which is a pump, it is the right ventricular end-diastolic pressure just before the onset of isovolemic contraction. There are two main components of the Guyton model. One is that the heart can only eject the blood that has returned to it. It cannot eject any blood extra to that. That's the first principle. And the second thing is, because most of the vascular volume is in the systemic veins, the heart can do little to change the filling of the veins, but affects the venous return primarily by lowering the right atrial pressure, or the CVP. So we talked about the limit, if you remember, the top, the flat part of the Starling curve. When you get there, they call it a wasted preload, because giving more fluid at that point only increases the filling pressure without a change in the stroke volume. And what was the limit on the venous return was that when you get the CVP less than 0, because, or that's in a spontaneously breathing patient, or less than pleural pressure, and a patient is on positive pressure ventilation, because then your downstream is not your CVP, but it's the point of collapse of the vein. So these curves show you that a CVP, which is this point, can change for many reasons. If you change your cardiac function curve, if you give somebody a bit of inotrope and the cardiac function curve goes there, the CVP changes, goes down. So if the cardiac function changes, the CVP changes in the opposite direction. Or you can change the venous return. You change the venous return by giving volume, or changing the compliance of the venous system by giving norepinephrine, for example, which moves more volume from the unstressed component to the stressed component. And in this condition, the CVP and the cardiac output change in the same direction. So that was about theoretical background. So I wanted to show that the CVP basically is an indicator of how the cardiac function and the venous return function interact. And it's impossible to make any sense of a CVP if you don't know what the cardiac function is. So now we talk a little bit about the measurement, because anything that you monitor, you need to measure it accurately, precisely, and you measure what you think you are measuring. I'm not going to talk to you about the technical detail, just a few points about the measurement. So zeroing the transducer, usually nurses do at the bedside, but doctors have to pay a lot of attention to that too. So zeroing done at the level of the mid-heart or mid-right atrium, which in adult is about 5 centimeters below the manubrium sterni. But in ICU, to make things simple, we go in the mid-axillary line and the intersection of that with the fourth intercostal space. We zero the transducer at that point. We zero it to 1 atmosphere. So we call it 0, but that's really 760 millimeters of mercury, 1 atmosphere of pressure. And then we open it to vascular pressure and we call it 0. So the one important thing is that we zero it to the atmospheric pressure, not to transmural pressure, which is for every tube or everything that has air or fluid in it, is the difference between pressure inside and pressure outside. What is the pressure outside for the CVP or cardiovascular system is a pleural pressure, which we don't normally measure. And it's very important for somebody who's on positive pressure ventilation, especially if in high PEEP, to know that number, but we don't. So that's another corollary of this, that we always have to measure CVP at a certain point, which is end expiration, because at that point, the pressure, pleural pressure, is closest to the atmospheric pressure. So you all know these, you know how to level the place that you want to find there and to measure your, zero your CVP transducer. Some people do it with the so-called Carpenter level. And sometimes you use a laser pointer to find that point. As you can see, a little bit of a difference up or down can change that 10 centimeter. And this is a study, a nursing study that I saw in a presentation by Dr. Pinsky, that if you do it visually, you can be wrong as much as 10 centimeter. which is a large number for CVP. You know, if you divide by 1.36, that's 8 millimeters of mercury. If you do it at Carpenter's level, you know, still can be wrong, but laser, you know, could get it right most of the time. Another thing is that it's very important that the end of your catheter and where the transducer is are at one level. Doesn't matter how your tubing travels, it can go up and down, but the end of these two tubings should be at the same level. If your transducer is below where the end of the catheter is, for example, in this example, 10 centimeter, 10 divided by 1, you know, 0.367, 0.3 millimeters of mercury. So your pressure reads at 12.3 millimeters of mercury when it is really only 5 millimeters of mercury. So it's very, very important to know after you zeroed where the level of your transducer compared to the level of your catheter. This is another example, which is the end of the catheter. Again, you know, we sometimes don't think about where the end of the catheter is. Dr. Cox used to show this to us when we were fellows a lot, and to the fellows while he was teaching them. So consider these two. Oh, why it is not working? Okay. So we zeroed the transducer here in both conditions. In condition A, the end of the catheter is here, and the condition B, the end of the catheter here. What do you think will be the CVP reading here? What do you think will be the CVP reading here? I give you 10 seconds to think about this. So in the first condition, this transducer here, zeroed here, sees 10 centimeter of water, reads 10 centimeter of water. Here, though, it's 40 centimeter below the surface of water. It was zeroed here. So there's minus 30 centimeter and plus 40 centimeter. So it reads minus 30 plus 40, which is 10 centimeter of water. So you know the end of it is here. So it shows the same pressure, though it's in a completely different place. So we have to make a note of where we zeroed it, where the level of transducer and the end of the catheter is, where the end of the catheter is. Another thing is that if you remember, we said that we measure, the best place to measure the CVP is at the onset of isovolemic contraction. So it's important to look at the waveform and have, if you can have an ECG with it at the same time, that helps. You all remember CVP had three components, A, C, and V. Atrial contraction, C was, you know, the tricuspid valve buckling, and isovolemic contraction, and V was the atrial filling. So the best place to measure the CVP is at the base of the C wave on the CVP. And if you have a CVP which is like this, you know, quite high A wave, then the difference of these two is quite significant. If you don't have that, if you can look at the ECG and the CVP at the same time, again, remember, we said at the onset of isovolemic contraction, so the S wave, if you draw a vertical line where it cuts the CVP, you can read that at the base of it. In this example, is 12 millimeters of mercury. We talked about reading the CVP at the end expiration, because that's where the pleural pressure is closest to the atmospheric pressure. So if the patient is breathing spontaneously, you read it just before it falls with inspiration, because that's a normal response. If the patient is on positive pressure ventilation, you read it just before it rises with inspiration. So how do we, if, you know, this is an example of pulmonary artery wedge pressure or occlusion pressure, but the CVP is the same. One way to know that is that you can connect a line here to your inspiratory expiratory limb here and connect it to the transducer. It's a column of air, and it can read, it's a bit dumped, but you can make a sense of where the expiration is going to end. And you read pressure there. In this example, it's 7 millimeters of mercury. So we talked about how to measure the pressure. We talked about what the physiological meaning of CVP is. Now we're going to talk about what information we get from a CVP. The traditional teaching when we were in medical school, and 20 years ago, was that we learned something about the blood volume, fluid responsiveness. Even people thought it gives some information about the occlusion pressure and the pulmonary artery, or the left ventricular and diastolic pressure. So this is a very old study from Shoemaker Group, 1984. They gave a bunch of people indocyanine in green, which is an indicator to measure total blood volume. As you can see, there is absolutely no relationship between dehydration or volume excess, and the CVP. Teboul and Michard in 2002 looked at all the studies that were done without correlation of CVP and fluid responsiveness, responders and non-responders, and they saw that absolutely there was no differences between the people who responded and people who didn't respond. There was a tendency that if you had high CVP, you were not a fluid responder. One of those studies was the Wagner studies that I put here, for example. As you can see, at the same CVP, you could have a negative response with fluid or a positive response. Or you can see at the same level of cardiac output, you can have a low CVP or a high CVP. So individual CVP would never predict if you're going to have a response or if you're going to have a positive response or negative response in your stroke volume. Kumar and Parillo looked at the other measures and they saw that CVP, again, cannot predict stroke volume or wedge pressure. So it's not a poor man's swan. So Marek did a systematic literature review in 2008 and all the studies that were done to look at the CVP and fluid responsiveness or volume status of the child, of the patient. So most of these are adult studies. There were 24 studies with about more than 800 patients. In those that looked at the CVP and blood volume, the correlation was only 16%. And in those that looked at the CVP or change in CVP and fluid responsiveness, the correlation was only 0.1%. So he made a pooled ROC curve, receiver operating curve for CVP and fluid fluid responsiveness, and the correlation was 0.5, which is as good as flipping a coin. And you can compare that with this curve, which was done years later when people looked at the passive leg raising and fluid responsiveness. And in that, as you can see, the correlation was 0.96. So 1 being ideal. So if a test is as good as flipping a coin, the correlation will be 0.5. And as it gets better, then the correlation will be better until you get to 1, which is the ideal test. So this was from the ARISE study, which is the Australian study at fluid responsiveness. And this is more than, I believe, 3,000 patients. And there was absolutely no relationship with fluid volume administration to CVP, delta CVP and fluid that the patient received, or delta CVP and change in the mean arterial pressure. So I said all things that CVP cannot show us. So is there anything that CVP can show us, or what information we can get from CVP? So we can say with some certainty now that there's no correlation between CVP and blood volume. A main reason behind that is that most of blood volume is in so-called unstressed component of the vasculature. There is no relationship between CVP or change in CVP and fluid responsiveness. And the main problem that I have with CVP, not I, people who have done more research in this area have with CVP, and I also, is that people chase a certain number, the so-called goal-directed therapy, which has started with Rivers. They think that there is an ideal CVP that every sick patient with shock should have. And if the patient does not have that number, then they give him fluid to reach to that number, and that's what causes the problem. So there are some certain things that we can say with some certainty. One is that the high CVP is always abnormal. So if you have a patient who has a high CVP, there's something wrong. And again, as I said, to understand the CVP, you need to understand the venous return and the cardiac function return. So either there's a problem with cardiac function, or there's a problem with venous return, venous compliance, and the interaction of those two together. The other thing that is always almost correct is that in normal people or in people who are fluid responsive, usually, almost always, there's an inspiratory drop in the CVP with the spontaneous breathing. You cannot say that when the patient is in a ventilator. So if a patient, I'll show the graph for that to you in a minute, but if the patient shows that, demonstrates that, then that's a sign of fluid responsiveness. If they don't have that, then they probably will not respond to fluid. Another thing you can say by looking at the CVP is that if a patient's CVP goes up with inspiration, a spontaneously breathing patient, again, because that happens normally on a patient who's on a ventilator, that can be a sign of RV problem. So if the RV filling is limited, in adults, the classic examples are tamponade, severe asthma, heart failure, RV failure, RV infarction, the CVP goes up in inspiration, and that's another helpful. So we need to look at the CVP waveform also, in addition to the average number. So this is a picture for inspiratory fall in the PRA or CVP, pressure in the right atrium or CVP. This is from Magder again. As you can see, in inspiration, the CVP drops. So what that does not tell you, that tells you that you are on the Frank-Starling curve, on the ascending limb of the Frank-Starling curve. And if you give fluid to the patient, the cardiac output probably will go up. If the CVP does not drop with inspirations, like this picture, then it tells you that you're probably here on the flat part of the Starling curve. So your CVP is, by giving fluid, your CVP will go up, but your cardiac output will not go up, which is the definition of fluid responsiveness. So I think that's something helpful, but that the patient should be breathing spontaneously. There are other things that, I don't have a picture for it here, but if you have a patient with ARDS, that Pinsky did a study some years ago, if these patients had low CVP and they put them on high PEEP, a lot of them had drop in cardiac index. So again, that has not been proven, but if you have a patient with a CVP of less than 10 and they have ARDS, and you're going to put them on a PEEP of 12, 15, there's a high chance that they are going to drop their cardiac output. So you might consider starting some vasopressors or giving a small volume bolus before you increase your PEEP. Or if you see that phenomenon, be ready to do that intervention. So the question is now then, why we monitor CVP? So whatever we monitor, our measurement should be accurate and precise. It should show what we think it shows. And so if we look at CVP in its physiological meaning, that it shows the balance of heart and venous return functions, but it's not showing the volume status, it's not the fluid responsiveness or indicator of LV function, I think that then changes our attitude towards CVP. You're not going to pour fluid into people to bring their CVP up to an arbitrary level, to so-called optimize their hemodynamics. Also, we should be looking at the waveform of the CVP. This is an example from Magder. You all remember from your medical school, or if you do cardiac, intensive care, hepatojugular reflux, you put your hand on the liver and press to see what happens with JVP. Normally, when you do that, the CVP goes up for about 5 to 10 seconds and then comes down. If the CVP stays up and doesn't come down, that's a very reliable sign of RV compliance problem, RV dysfunction. So you can get other information by looking at the CVP waveform. Again, this is another example of the fluid responsiveness with CVP. We need to have an idea about where on the Frank-Starling curve the patient rests, the patient sits at the moment, because if you're here and you give them fluid, you gain a lot in the cardiac output, and the pulmonary, the extravascular long water doesn't go up that much. But if they are here on the flat part and you give them fluid, the cardiac output doesn't change, but the filling pressure goes up a lot and the extravascular long water goes up a lot, which causes a lot of problems. So that which brings me to this, that not even the most sophisticated invasive monitoring in the world will do any good to the patient. What you monitor is coupled to a treatment that improves outcome of the patient. So why we are monitoring the CVP, that's what we ask ourselves, because monitoring by itself will not change what happens to the patient. What we do to that, though, might be good for the patient or be bad for the patient. If what we do is to pour fluid into the child without looking at the other parameters of hemodynamics, then that's causing harm. This came out about a month ago. This is a consensus document from the European Society of Pediatric and Neonatal Intensive Care. And they have also suggested that isolated CVP measurement is of limited value, and CVP should not be used as a sole parameter to guide fluid therapy. One should not give fluid bolus on the basis of a low CVP alone. And specifically, a rise or high levels of CVP should be avoided. What they suggested was that, they have suggested that in an unstable, critically ill child who has not responded to initial treatments to place a central venous pressure, but then what to do with it, they suggest that trends in CVP may provide more important information regarding evolving right heart dysfunction than single CVP numbers. And to assess the fluid responsiveness, they suggest to use a velocity time index across the aortic valve and not the CVP nor the IVC collapsibility, because IVC collapsibility at its best is a representative of CVP, and CVP on its own is not correlating with fluid responsiveness with cardiac output. So Marek put all of these things together and in his so-called 6 guiding principles of fluid resuscitation. So we have to ask ourselves, why do we give fluid resuscitation? The answer is to increase cardiac stroke volume or cardiac index. So we need to know if the patient is fluid responsive or not. As it happens, only about 50% of all septic patients are fluid responsive. Imagine if there was a dangerous treatment that only 50% of your patients responded to. Would you give it to everybody, hoping that it is one of those 50%? The second guiding principle for him is that clinical signs, chest X-ray, CVP, and ultrasound are not reliable. Obviously, this is a lot of it pertains to the adult intensive care, and in pediatrics, a lot of times we have to put a lot of things together, including clinical signs plus other parameters to have an understanding, not exact knowledge of where the stroke volume stands. So multiple studies have shown that the passive leg raising maneuver or a mini fluid challenge, because when they do the PLR maneuver, there's about 5 cc per kilo fluid from the lower extremities that is, if you will, transfused temporarily into the system. And then you put the lower extremity down, then the fluid goes back to the lower extremity. In mini fluid challenge, that's the same, 5 cc per kilo. And you have to give it fast, but you need to couple it with the real-time stroke volume monitoring. That's one problem in pediatrics, because we don't have very good practical real-time stroke volume monitoring at the bedside. This could be anything from, as we said, a velocity time index or a Doppler probe in the esophagus or a pulse contour monitoring. The hemodilution methods are a bit cumbersome in pediatrics because you need to put a catheter in the femoral artery. But in adults, they do those. The hemodynamic response to fluid challenge is a small, sometimes only, for it to be positive, the stroke volume has to go up 10%. But it's usually short-lived, so it can be as short-lived as 5 minutes or 20 minutes. So you have to check the stroke volume frequently to see if it happens. And the other corollary to this is that the fluid responsiveness does not mean that you have to give fluid to the patient. You have to assess the patient's clinical state, see if it's going to harm them if you give them fluid bolus, or are they already in pulmonary edema, or they have already had no renal function. So those are all important things you have to consider before you give a fluid bolus. And high CVP, again, it's anybody's guess. What is a high CVP? I told you a normal CVP in a sitting or a standing child or adult is about 0 to -1. So probably more than 8 millimeters of mercury is associated with increased mortality and increased incidence of acute kidney injury. This was a very good study that came out last month. And the question was that if we use dynamic assessment of fluid responsiveness, would it improve outcome in septic shock rather than giving fluid bolus to everybody? So it was a prospective randomized controlled trial, 13 hospitals in the UK and US. And so the intervention study was guided by the passive leg raising and assessment of cardiac output. And the other arm was the usual care. So they saw that, you know, I forgot the total number of the patients. Oh, it's here, about 140. The incidence of acute need for renal replacement therapy was less than a third in the group that were given fluid on the basis of a dynamic assessment of cardiac output. Also, need for mechanical ventilation was half in these patients. The total amount of fluid that these patients received was about 3 liters in 72 hours. The total amount of fluid that these patients received was about 5 liters. So there was a big difference. So the conclusion was that physiologically informed fluid and vasopressor resuscitation demonstrated lower lead fluid balance and reduced risk of renal and respiratory failure and a stay in ICU. So you all know how to do passive leg raising. The problem with passive leg, it has obviously, you know, you have to be precise. You cannot do it from a patient supine. You have to do it with a patient at 45 degrees. Then you put the head down, the feet has to go up. They recommend that the feet should not be lifted with hands, but it has to be the bed. And then you have to measure the stroke volume during it and after it in intervals. In children younger than 5 years of age, it's not very easy to do. So in adults, as I showed you the ROC curve, this test is 96. The correlation is 0.96 in predicting fluid responsiveness. So that brings us, I probably have a few more minutes. What about the sepsis and fluids? Because the CVP, as I said, it's only as important as what you do with it. So Marek argues that sepsis is a vasoplegic state. Obviously not all cases of sepsis, but all of you have seen, you know, children that you pour fluid into them, their blood pressure doesn't move. So there's a lot of venodilation, and because of that, unstressed blood volume has gone up and the venous return has gone down. There's a poor myocardial response to fluids in sepsis, meaning that when you give fluid at the cost of a slight increase at the stroke volume, you have a lot of increase in filling pressures. Also, there is increased endothelial permeability and development of endothelial gaps because of shedding of the endothelial glycocalyx. You can actually measure the products of endothelial glycocalyx shedding in the circulation. So there's a very famous American philosopher, his name is Homer Simpson. He would say "dough" because giving volume disrupts all those three components. Giving volume bolus, fluid bolus, vasodilates the patient, stretches the myocardium even more. That myocardium already had problem handling the fluid and causes more shedding of the glycocalyx. So we do an intervention which disrupts all three mechanisms that do harm. This is a schematic representation of, this is the glycocalyx layer, which is 2 layers. And in sepsis, it disrupts and causes extravasation of fluid to the interstitium. And also we have a lot of nitric oxide production. You know, if you have ever used methylene blue in treatment of sepsis, which looks like a miracle in patients that it works, it's not a common treatment, but I've used it a few times. Methylene blue is a nitric oxide mopper. It mops it off, it cleans it up, and that's the reason it works in sepsis. So I'll talk a little bit about fluid bolus and where it started. This is an article from almost 200 years ago, that's how IV fluid treatment has started. This is a girl that was called Blue Girl of Sunderland in England who had cholera. As you can see, she's very vasoconstricted, blue, and this is her. Somebody, you know, made this a sketch before the girl died. Dr. Lotta, who was working in Leith in England, or Leith, wrote an article about 3 cases. And this girl has become immortalized. Her name is Isabella Hazard. She was 12 when she died, and even the day of her death in that picture. So one of these patients survived, and he says that he put a tube, a metallic tube, into the basilic vein. Having no precedent to guide me, I proceeded with much caution. It seems they were more cautious than, and ounce after ounce of fluid closely observed the patient. The sunken eyes and fallen jaw, pale and cold extremities bearing the manifest imprint of death signet began to glow with returning animation. The pulse returned to the wrist. So maybe we should be as cautious as people were 200 years ago. high CVP is one of the most important factors inducing acute kidney injury. And it seems that when you get to about 8 to 10, that's where the curve becomes more steep. So this is from Didier Payan in France. In a group of septic patients, high CVPs was worse than low blood pressure in inducing acute kidney injury. So we're always worried about low blood pressure, which is very right, we should be. But high CVP is worse than hypotension in inducing acute kidney injury. And there is now a correlation of they have found it in large number of patients, for every millimeters of mercury acute increase in CVP, the odds ratio for acute kidney injury in 5,000 patients went up by 6%. In a group of pediatric patients in South Korea, who were all septic patients, they saw that CVP less than 8 had the lowest mortality, and compared to a CVP more than 12, at 6 hours, 24 hours, 48 hours, 72 hours, the mortality was 5 times higher if your CVP was 12, more than 12, compared to the ones that have a CVP of less than 8. So what we can say that there is enough evidence to be alarmed by a high CVP, as it is associated with increased mortality and increased AKI. What I can summarize is that CVP is an indicator of interaction between cardiac function and venous return function. There is no correlation between CVP or change in CVP and volume status or fluid responsiveness. CVP trend is more important than single CVP measurements. Monitoring CVP response to inspiration or to PEEP may provide useful information. You have to look at the waveform. You have to know the exact number, so don't look at the average number. Chasing a certain level of CVP for people who are very interested in goal-directed therapy to optimize hemodynamics can be harmful to the patient. High CVP, and whatever number you want to choose, more than 8, is associated with worse outcomes. Being fluid positive is associated with worse outcomes. And so this Paul Marek is a sort of an agitator or disturber. He calls fluid resuscitation iatrogenic saltwater drowning, and he calls surviving sepsis guidelines not surviving sepsis guidelines. And if you read Arabic, this is from Adanis, the famous poet, and this is the Arabic translation of that, and this is the Farsi translation of that for those who read Farsi. So thank you very much, and I hope that it has been useful.
Thank you, Dr. Mohseni, for this amazing lecture. As a pediatric resident, I'm learning a lot from these lectures, and I'm enjoying this. And thank you for sharing your experience, your knowledge, and your time with us. I really appreciate it. So, Dr. Qari, would you like to add anything to this? Or I see Dr. Shaif Sada has a question. So, Dr. Shaif Sada.
Thank you so much. Thank you so much, dear Dr. Mohseni, from your very useful and great lecture. I have a question. This question is an old question for me and repeated in my mind. Very, very, very important. It is an important question in my mind. Suppose that a patient is on ventilator, and all of the changeable position, such as the fluid and the pressure of the ventilator and the altitude of the bed and all of the other changeable situation is fixed. In this situation, if we measure the CVP in the, for example, the first minute, what's the difference of this CVP by the CVP that we measured, for example, at fourth minute? I think when the all position is fixed, the CVP is a good indicator for the hemodynamic status of patient, because the variation in CVP measure is not influenced by any changeable position that we could suppose for the patient. For example, the ventilator pressure and the fluid that patient is received, or other things. Now, what's your opinion about this? I mean that when we can compare the first CVP by the second CVP. Why could not we use the CVP for the hemodynamic monitoring of the patient?
So thank you very much for your question. I didn't say don't measure the CVP. You know, I said that, first of all, one measurement does not have any meaning. Two, you have to ask yourself what we are looking at. As I said, CVP represents the interaction between venous return and cardiac function. Also, because the CVP, you know, as we talked about, the pressure, transmural pressure is pressure inside minus pleural pressure. If you're on high PEEP or on ventilatory pressures, it would affect the CVP. Yes, by all means, we have to, if we have a CVP monitor in place, we have to follow the changes in CVP, because we know that high CVP is bad. It shows that there is something wrong with the compliance of the RV or the function of the RV, or something else has happened. So if your CVP is going up, you have to ask yourself, what is the cause for that? You have to go back and make sure nobody put the transducer below the level of where it was 0. You have to make sure, you know, that everything else, you know, is fine in measurement and in calibration and zeroing of the CVP. And yes, if it is going up, it could be the first sign that your RV is becoming more stiff, you know, that if you have problem with perfusion of your RV, or if your pulmonary hypertension, you know, is getting more worse. So those are the things that you have to look at. I don't say don't measure it, don't pay. If it's in place, follow the changes in CVP and look at the waveform and see how it changes with, you know, breathing pressure changes. If it's in a spontaneous patient, if it's in a patient on high PEEP, you know, then the low CVP might be a risk factor that shows the patient might be at risk of cardiac output dropping with the high PEEP. So those things are helpful. But what I wanted to tell you is that don't give fluid bolus to people to reach a certain CVP, because that was, you know, the surviving sepsis guidelines tell you give 40 to 60 cc per kilo fluid in the first hour based on poor evidence. They say that do that in resource, this is the latest version, resource-rich countries. They say in resource-poor countries, based on good evidence, which is the FEAST study, don't give fluid bolus. You know, physiology of man should not be different. So what I'm telling you is that to use your, you know, at the bedside, your clinical exam, plus what the monitoring tell you in following the patient through their ICU course, and see if there is a change from where that could have been. I hope.
Yes, thank you so much. Thank you so much.
Thank you, Dr. Mohseni, for your great explanation, and also thank you again for this amazing lecture. We really enjoyed this lecture and also the previous two, and thank you for joining us again. Thank you so much. Yeah. So I see that Professor Humpl has been successful for sharing his slides. So can you hear me, Professor Humpl?
Yes, I can hear you.
Yes, okay. So we are ready with you whenever you are.
Perfect. I thank you for your patience. I had really to make some changes within the Mac to allow screen sharing. So it's wasn't that easy, but finally I succeeded. So I have to get you out of the window. I'm not sure how this is being done, because otherwise I only see half of my slide. Well, let's try it. How do I get, I have you in the window. I don't know why.
So Tilman, in my experience, I could not use the presenter view, you know, I had to just put it as a regular slideshow.
No, that's fine, but I see some names and you in a window in the middle of my screen. That's why I'm a little bit, but okay, you're gone.
Okay, I'm not there anymore.
Whatever, it's funny. Okay, so thanks again for giving me the opportunity to talk. I learned a lot already in the previous two talks, and I hope you're able to learn a little bit in my talk. So if I look to pulmonary hypertension, which is a very fascinating topic, and we can talk about it for hours and days, but the term was actually coined in the 40s to 50s of the last century, and at the same time, Bjorn Ibsen started his first ICU in 53 in Denmark. So there seems to be some things that go together between pulmonary hypertension and ICU. But fast forward, what do we expect for pediatrics in pulmonary hypertension and sick children? Looking at a big study from the Pediatric Health Information System database, who looked at readmissions in children with pulmonary hypertension, they included about 13,600 patients between 2005 and 2014 admitted to the hospital. And you can see the split between the ages. And a ton of these kids had either BPD or congenital heart disease. You see 3,500 with bronchopulmonary dysplasia and 6,100 with congenital heart disease. And you can also see on the screen that ICU patients or patients were admitted to the ICU in about 60%, and some of them ended up on ECMO. We come to that later, and some of them ended up on inhaled nitric oxide. Looking now at the ICU admissions, this is even a larger study from the US. They looked at 670,000 patients admitted between 2009 and 2015, and they saw about 2.4% admissions with pulmonary hypertension. And the smaller number here is patients with primary pulmonary hypertension, and a larger number with secondary pulmonary hypertension, so 15 versus 85%. So it's important. It's something we still have to deal with. And even more important is that the mortality for patients with pulmonary hypertension is significantly higher than for patients without pulmonary hypertension. You can see on the left side, the bars, no pH around 2.3%, which also is pretty similar to all admissions. And if it goes to pulmonary hypertension, it's 7%, primary, secondary, there's also a little bit of a difference. In hospital cardiac arrest, also a big problem that sometimes ends up in the ICU. And it's a study from Philadelphia just recently published. They looked at patients who had an echo done 48 hours prior to in hospital cardiac arrest, and 35% of them had elevated PA pressures. They also had decreased RV systolic function and right ventricular dilation. But at the end, the evidence was not really, evidence of pulmonary hypertension was not really associated with first survival. But what we learned from the study is that PH is obviously more common than in patients with in-hospital cardiac arrest than previously appreciated. And what comes together there, maybe it's something like a hovering, elevated, lightly elevated PVR, which actually got aggravated with hypoxemia, asthenia, and other arrangements that we don't actually appreciate all. So this is maybe something you've seen before. It's a long list of possibilities why you can have pulmonary hypertension, and most of these things are also true for pediatrics. So it's an adult adult work. And I thought it's not worthwhile really to go to each condition and show an example. So I decided to put it in a little bit in groups. In the beginning, just reflecting the pathophysiology. So pulmonary hypertension, you have elevated pulmonary artery pressure, resistance. With this, you may have some right ventricular diastolic pressure that's elevated end-diastolic volume in the right ventricle. Your septum shifts towards the left. You have with this some right ventricular failure, sometimes elements of ischemia on the right ventricle, which leads to arrhythmia. Your left ventricular end-diastolic volume goes down. Your cardiac output goes down. You have more metabolic acidosis, which leads makes your pulmonary arterial pressure and resistance go even further. Parallel to that, with larger pulmonary artery pressure, larger pulmonary arteries, you may have some airway obstruction on different levels. You end up with VQ mismatch. You have more interpulmonary shunting, more dead space, more hypoxemia, hypercarbia, respiratory acidosis, and the combination of hypoxemia and respiratory acidosis also let get your pulmonary artery pressure up. So this is just as an example. This may be in the different features I'm going to show you in the next 15 to 20 minutes. Different, but this is just as a baseline. In the ICU, we have a dilemma. There is really no comprehensive assessment of pulmonary hypertension. We see less and less pulmonary artery lines, which is maybe good for to some sort. A lot of complications. We only have the possibility to estimate by echocardiography, but estimation can be wrong. It can be underestimated and overestimated. And if you look at studies, you really have to have a good sonographer or interpret the conditions that you see on the screen in the clinical setting. And furthermore, there is actually no real guidelines for therapy, what you're going to treat in the ICU, which number. So there's more or less a consensus, but that mean pulmonary artery pressure of greater than 25 millimeter mercury in the ICU or over half systemic warrants some sort of intervention. But as I said, not always, because you don't know, is the mean pulmonary artery pressure really bigger? And you should have on top of it some signs of low cardiac output. So what I put together is a couple of examples from the NICU, from the cardiac ICU and non-cardiac patients, as a lot of physicians in the pediatric world look after a mixed unit and not only a straightforward pediatric ICU. So let's start with the NICU. As we all know, at birth, pulmonary blood flow increases, pulmonary vascular resistance decreases the first couple of days to weeks, and with this, the mean pulmonary artery pressure also drops over time. This is work from Abe Rudolph. I think that Peter Cox mentioned that before. That's work in LAMS. It's actually what we persistent pulmonary hypertension of the newborn is the earliest form of pulmonary hypertension that we may see in the ICU. On this little picture, you see the normal pulmonary blood flow with all the shunts closed. That's how it should be. Blood returning from the vena cava to the right atrium, to the right ventricle, going to the pulmonary artery, and then returning oxygenated to the left atrium, left ventricle, going up to the system. And in persistent pulmonary hypertension of the newborn, there's a failure of closing the shortcuts. Between the two atria, the foramen ovale, and between the pulmonary artery and the aortic arch, the ductus arteriosus. And you see as the arrows point, there is a right-left shunt in both areas, which means deoxygenated blood goes directly to the left side, bypasses the lungs, and the rest of the deoxygenated blood goes to the pulmonary artery duct to the descending aorta. And this is something that's not compatible with life for a long time. The incidence for PPHN is pretty similar in Europe or North America, about 0.5 to 6 per thousand live birth. And at the pathology, there's a failure of the circulatory transition after birth. Hypoxemia is involved, and then the right to left shunting of blood. The maladaptation of the pulmonary vasculature is triggered both by maternal and neonatal problems for mothers. It's maybe diabetes, asthma, obesity, medications for the neonates. The boys have no problems. C-section is a risk factor. Kids born before 37 or after 41 weeks, and small or large for gestational age. There's also genetic abnormalities which may play a role, and surfactant issues have been identified. The most important differential diagnosis to that is alveolar capillary dysplasia, which is a rare interstitial lung disease, has a disordered development of alveoli and distal airspace. And I'm going to show you a histology slide in a second. And there's basically a premature growth arrest in the lung, and recently a genetic problem, the FOXF1 genes have been detected. So here is the promised slide. You see in the upper panel, patient with alveolar capillary dysplasia. To the left, there's a collagen 4 stain, and to the right, CD34 stain. You see sparse alveolar capillarization. There's basically no capillary loops reaching the alveolar surface compared to a normal lung, normally developed lung on the bottom of the slide. Paulo Olmescan, who was a fellow at the Kids, put a series together in 2007. All of these patients presented as PPHN. One had actually, unfortunately, also hypoplastic left heart. The presentation was for most of the patients in the first 1 or 2 days of life. 5 of them went onto ECMO, and most of them died within the first couple of days. The only treatment option for them would be neonatal lung transplant, which is not available everywhere in the world. So if you have a patient with pulmonary hypertension over 32 weeks gestation with refractory hypoxemia, this group from France put together a little diagram. They suggest to rule out other causes of PH. So could be asphyxia, could be meconium aspiration syndrome, could be pulmonary hyperplasia. And if you find something like this, then it's okay, then treat it. If not, then look for chromosomal abnormalities. I mentioned the FOXF1 testing, discuss a lung biopsy, and go from there. Congenital diaphragmatic hernia is another issue that causes PH in the newborn period, abnormal diaphragm development, and herniation of abdominal organs into the chest cavity. And with that comes a variable degree of hyperplasia of the pulmonary vessels. There is impaired alveolization, and of course, there is also a reduced cross-sectional area of the pulmonary vascular bed, and most of these kids also show on histologic sections thickening of the vessels. Vein of Galen malformation, moving away from the lungs and the chest. This is a recently published study of 12 neonates who were diagnosed with vein of Galen malformation. They all had moderate to severe cardiac failure and systemic pulmonary hypertension. 5 of them were successfully embolized, but nevertheless, in this small group of patients, there were 60% patients who did not survive. Moving on to cardiac patients, the past, and I'm talking now about the 50s to 60s. This is numbers from Kirkland from 63. You can see with the red frames to the left side, this is the left ventricular or the arterial blood pressure 100/84. You can see this patient, the right ventricular pressure was 84/63, and this is similar for for a couple of patients. So these were patients after ventricular septum defect repair. He had a long list of patients who all had postoperative systemic pulmonary hypertension. Not good, because most of these patients die because the right ventricle gives up. Kate Brown in the early 2000s talks about pulmonary hypertension still being an important factor on postoperative morbidity and mortality for cardiac patients. There's other things that's being mentioned, like diaphragmatic palsy and chylothorax, but usually these are not issues that are going to be life or death. Also around this period comes one of the larger studies about how common we see severe pulmonary hypertension after pediatric surgery. That's a study from Scandinavia. They included kids under 18 years of age who had underwent surgery between 94 and 98. They collected 1,349 patients, most of them neonates and infants, and they saw severe pulmonary hypertension in about 2% of the patients, with 2 deaths within the first 30 days of surgery. Today, it's very difficult to give good numbers about prevalence and incidence. It's very difficult to determine because we don't really look for it in a really good and strategic manner. And I think it's also a little bit related to the specific patient population of the institution. What are the congenital diagnoses? How many patients with more tricky diagnosis like TBVD or truncus or transposition of the carotid arteries are being looked after? And also very important, chromosomal abnormalities. It's not only the trisomy 21 patients who may cause trouble after surgery, but also kids with other chromosomal problems. What has changed over the, let's say, 60 years? Since Kirkland presented his numbers. Yes, all the patients are at younger age now when they undergo surgery. They're much more robust candidates to be operated on. The surgeons have better techniques and also use better techniques during cardiopulmonary bypass. Nevertheless, this is an example from the time when I still worked at the kids. That's a patient with supracardiac TPVD, had a mild obstruction, uneventful OR, and you can see this is arterial pressure line. A couple of hours after coming out of the OR, the pressure went down. Pulmonary hypertension was suspected, inhaled nitric oxide was started, and you can see the hemodynamics normalized again. Another issue that becomes more and more common, or people pay more attention to, is pulmonary vein stenosis. You can see on the left CT scan, a very narrowed pulmonary vein entering the left atrium. We appreciate now discrete focal stenosis, progressive pulmonary vein stenosis, and diffuse hyperplastic pulmonary veins. They are common in or seen in patients with congenital heart disease, without congenital heart disease, but clearly prematurity plays a bigger role now in patients with this condition. Usual age at diagnosis is about 7 months for all of them. Unfortunately, the prognosis for these kids is not very good. There's usually progression in this disease, and the long-term survival is very limited. Current interventions include surgery, which the pulmonary veins usually don't really like. After surgery, in a lot of cases, the stenosis gets even worse. People tried to use catheters to dilate the vessels or put stents in, but this is for the most part of the patients also only something that can buy some time. transplantation, but a lot of times heart lung transplantation is something that's considered, and experimental therapies, imatinib, lorsantan, studies are going on, but currently not really with promising exams. Last part would be non-cardiac patients. This is BPD. This is something I only want to touch base on briefly. That's what we're going to see more and more as more and more premies are surviving to infancy and childhood. If a patient with an X-ray like this hits the ICU with a pneumonia, you can be sure that you see suprasystemic RV pressures and sometimes an RV giving up and the patient dying. Also newer in the past is that we see patients with cancer or cancer treatment, both in the pulmonary hypertension clinic, but also as in this publication from last year in cardiology in the young, patients admitted to the ICU. These were two neuroblastoma patients, rhabdomyosarcoma patient, pineoblastoma. They all had severe PH, went to cardiogenic shock and had high BNPs. You may see more and more of these patients as well in your units. It's unclear if it's so far, if it's the cancer, if it's the cancer treatment, a combination, or something underlying in the patient, him or herself, which we don't know yet. This is also a cancer patient that we had in Toronto a couple of years ago, chronic embolic pulmonary hypertension, something that we think in pediatrics is not very common, but to tell you the truth, I think we don't look for it. In a large study, top registry of pulmonary hypertension patients, only 40% or 40 to 50% of the patients actually had appropriate diagnostics to rule out CTEPH. This is a patient who had a Denver shunt that you can see on the right side, came in with suprasystemic pulmonary hypertension. People thought that's related to underlying new primary pulmonary hypertension. We did a chest X-ray and chest CT, and we saw the embolic changes here, and a very talented surgeon pulled out all these emboli, which you can see on the right side, and a couple of days after surgery, pulmonary hypertension was gone, and 2 to 3 years in follow-up, the kid had no pulmonary hypertension anymore. Moving on to treatment, one size doesn't fit all, which means not every patient should get the same thing, and it's sometimes difficult to decide what's the right thing to do. For sure, in the ICU, inhalation therapies play the largest role. Oxygen was already mentioned in one of the previous talks. You can also use prostacyclin or inhaled nitric oxide. Prostacyclin can also be given in an intravenous form. These are the mainstay things in the ICU, but also PDE5 inhibitors, either orally or intravenously, and we'll come to this in a minute. So the nitric oxide was molecule of the year in 1992 and has since been placed in every ICU. Selective, very selective on the pulmonary circulation, increases cyclic GMP. With this, puts down the intercellular calcium concentration and leads to smooth muscle exhalation. Good thing is it's very rapidly inactivated and has practically no systemic vasodilatory effects. The bad part is that it's become very expensive. Both Peter Cox and I remember on both sides of the Atlantic that it was very, very cheap in the mid-90s. Now it's very, very expensive. A little bit of a more cheaper therapeutic option is prostacyclin, which is also produced by the endothelial cells, has a very short half-time, can be given, as I mentioned, intravenously, but you have to be careful that there may be an increased pulmonary shunt, which reduces the PRO2 but also has significant systemic vasodilatory effects. So your arterial pressure may go down, but inhaled, it's actually very, very good and very useful. And Peter Riemensberger already in 2001 showed that inhaled nitric oxide and iloprost are actually similar effective. You see for baseline, and then inhaled nitric oxide, RPIs goes down, baseline up to normal again, and iloprost does the same. And if you add both together, it may go a little bit further down. So that's a pretty neat alternative that you can use. Sildenafil, since available since 2000, also reduces breakdown of cyclic GMP, has other side effects that are well known. Oral administration in kids and adults, actually minimal side effects, but in your ICU patient, the sildenafil needs to be absorbed with the gut. Otherwise, it will not be really helpful to use it. Intravenous application studied in 2003, Christian Stocker. He also saw a reduction in pulmonary vascular resistance, but also systemic vasodilation. And with this study in IV sildenafil in the pediatric world didn't really make it to the forefront. More recently, Florian Kipfmüller from the University in Bonn looked at patients with congenital diaphragmatic hernia, and he saw some responders to this, to IV sildenafil, and could see that there's really a better oxygenation, better vasopressor score. So this may actually slowly come back again. I personally also used it a couple of times, but clearly there's no good studies out there that it's perfect drug yet to be used in the ICU. What we all should be aware of is rebound pulmonary hypertension, which means that after turning off the nitric oxide or the therapy, your pulmonary artery pressure goes right up again, and the patient is much more at a risk to die than with his baseline pulmonary hypertension. Last but not least, mechanical support in this. With this, I mean ECMO. It's also recently published study by Morel, multi-center from the US. You can see the black bars are patients who died, and it's more or less over these time span, 50% of the patients who died, and this is true for a worse survival was in the patient over 5 years of age. Unclear why the group of patients between 6 months and 5 years had a little bit of better survival. But if you look at primary idiopathic versus secondary pulmonary hypertension, there was really not a big difference. So in summary, I think and I hope that I was able to show you that pulmonary hypertension is prevalent and an important feature in the pediatric intensive care. There's specific neonatal problems that we all have to deal with, but there's also different etiologies and problems in the pediatric population. We clearly don't identify all the patients at the right time. We have always to think about the pathomechanism behind the pulmonary hypertension and then choose the right treatment options. And with this, I thank you for your attention.
So thank you, Professor Humpl, for this great and informative lecture on pulmonary hypertension. We really enjoyed it and learned a lot. And thank you again for joining us and sharing your knowledge and expertise and also your valuable time with us. We really enjoyed it, and we hope to see you again maybe in person. We would love to have you in Iran. You, Professor Cox, and also Dr. Mohseni, we would really love to have you again in Iran and to meet you in person. But right now, we wish you only health in these COVID days, and maybe after these COVID days, we will have the opportunity to meet in person. So, Professor Gharib, if you have anything to add.
Thank you very much, Professor Humpl, and thanks a lot I appreciate your presence in our Congress. And also I should appreciate a lot the efforts and support of Dr. Mohseni, which who kindly invited and helped us to have our Congress. Dr. Mohseni invited most of our lecturers in the Congress. Thanks a lot, Dr. Mohseni, and thanks a lot, Professor Cox and Professor Humpl. Thank you very much.
Sorry, can I have 1 minute time to ask a question from?
Yes, yes, please.
Tilman, can you stay for a couple of minutes, or do you have to go?
I can stay.
So I had a question about sildenafil. Now this year there is a study, randomization of CDH babies with pulmonary hypertension to receive either IV sildenafil or inhaled nitric oxide in Europe. My first question was, if inhaled nitric oxide has not worked, because we know that in CDH as a general group, it has not worked, and both of these drugs work, through one common pathway, or final pathway, why then we expect the IV sildenafil work? Or is there any reason that if somebody did not respond to inhaled nitric oxide, give them IV sildenafil to see if they respond? That's the first question. Second one was that they used to, in about 10 years ago, to give sildenafil oral to mothers, pregnant mothers who had fetuses with CDH. And in some of them, the babies had pulmonary hypoplasia, so it was stopped in some parts of the world. But again, this year, in Europe, they have started to give oral sildenafil to mothers to see if it affects the pulmonary hypertension in the fetus and in the baby, newborn. So what? And you also mentioned that the sildenafil had led to some pulmonary hypoplasia and problems. So what is the effect of sildenafil in the fetus, that sometimes it can lead to problems with pulmonary development? And two, if inhaled nitric oxide does not work, why IV sildenafil should?
Yeah, these are $1 million questions, Hadi, and you know that. I personally think that sildenafil given to the mothers will not really make a huge difference. So how much of the medication will be absorbed by the placenta, and how much will get to the patient, we don't know yet exactly what's the right PK level for patients with for born patients with pulmonary hypertension. You know about the black box warning of the FDA for kids with pulmonary hypertension. So we used to give high doses of sildenafil, and unfortunately some kids died. And now it's a much lower dose. And if you give this lower dose to the mother, how much will go to the fetus? I personally think this will not be a big player in a change in the developing pulmonary vasculature. The other thing is, the other question, your first question regarding inhaled nitric oxide and sildenafil, or IV sildenafil. This is why I put Florian Kippmüller study in. There seem to be some of the kids, despite, or especially if it's the same pathway, who respond to one drug but not to the other. It's similar to what I said a little bit earlier. Some children, some adults respond to oxygen, others to inhaled nitric oxide. I think we're still a little bit away from understanding everything behind how these drugs actually work.
Okay, thank you.
Thank you, Professor Humpl. I see Dr. Sharifzadeh has a question. Dr. Sharifzadeh?
Excuse me. Thank you so much, Prof. Humpl. I have a question about the value of echocardiography in the diagnosis of pulmonary hypertension in ICU, especially for the patient on ventilator therapy. What is the accuracy of echocardiography alone echocardiography in the diagnosis of pulmonary hypertension in pediatric ICU, especially for these patients, the patient that is under ventilator therapy? Thank you so much.
You already pointed it out, and as you're framing your question, I think you can, to some extent, rule out pulmonary hypertension if you don't have a dilated right ventricle, if you don't have a significant pulmonary insufficiency, if you don't have a significant tricuspid regurgitation, your yield that there is really pH is very low. But if you have, on the contrary, a dilated RV who is barely functioning, even your tricuspid valve is competent, you may consider there's something on with going on with pulmonary hypertension. The gold standard right now is still a cardiac cath. So to get the exact numbers would be to put a line in. Everything on the echo, some people also call it a guesstimate or not an estimate. So it may help you. It may help you. It's not there, but it doesn't really tell you for sure it's there.
Thank you very much. Thank you so much.
You're welcome.
So thanks again, Professor Humpl. I see that we're past our scheduled time, so I won't waste any of your time. Thank you, Professor Humpl. Thank you, Professor Cox. And also thank you, Dr. Mohseni, for joining us again in this lecture, in this session. It was really an honor for me, myself, to listen to these amazing lectures and to learn a lot and to be here at your presence. And we hope to meet you again in person, actually. So just a quick reminder for everyone that tomorrow we're going to have 3 other sessions. So the one is going to be about COVID-19 and also nutrition and also psychiatry. So please join us in there. And also the last ICU session of this web congress is going to be on Saturday, November 7th. We would really love to have you there, and also I hope to see you there as well. So everybody have a great night, day, evening, wherever you are, and have a safe day. Goodbye.
Thank you.
Okay,
Thank you,
thank
Peter.
you.
Tilman.
Goodbye.
Thank you. Bye-bye.
Bye,
Bye.
Hadi.
Bye-bye.
Bye, Mariam.
Bye.